We're supposed to say thank you to thank you, Elsevier and the Journal of Pediatric Surgery for supporting this lecture. Bob Block is a hero and a champion. He's my hero because of his being a champion. He taught me, along with so many others, that children are the most powerful engine for the progress of civilization in any aspect. He thus made me understand that serving children is not nice because they're cute and we like our own kids and we like to play with them, but frankly, if we can provide better resources for children, we can actually build a better world. Bob is an emeritus professor of pediatrics and the immediate past Daniel C. Plunkett Chair of the Department of Pediatrics at the University of Oklahoma School of Community Medicine in Tulsa. He was elected by membership of the American Academy of Pediatrics as president-elect in 2010 and served as president from 2011 through 2012. He got his MD from the University of Pennsylvania and completed his pediatric residency at the Children's Hospital of Philadelphia. And he has another profession that has profoundly influenced all of our practices, especially in trauma. He was appointed the first chair of the newly formed Subboard on Child Abuse Pediatrics by the American Board of Pediatrics from 2006 to 2009 and continued to serve through 2012. In fact, he holds certificate number 1 from the American Board of Pediatrics in Child Abuse Pediatrics. He's certainly a fellow of the American Academy of Pediatrics, a former chair of the Academy's Committee on Child Abuse and Neglect. He's a former president and board chair of the Academy on Violence and Abuse. And we're pleased to have Bob join us today as he talks about all adults once were children. Ladies and gentlemen, join me in welcoming Bob Block.
Good morning. I'm changing the title of my talk after listening and being overwhelmed by the previous session. So my title today will be Effects on Stem Cells from Zebrafish with SNPs who undergo orthotopic epithelial cell replacement after transanal transplant during fetal surgery stimulating CD8 T cells. Actually, I found a new connection between pediatricians and pediatric surgeons and was delighted that you all discussed the color of poop. So we really will talk about all adults once were children. And I want to thank you for the opportunity to speak with you during your 2015 meeting of the American Pediatric Surgical Association. I want to acknowledge my friend and colleague, Dr. Michael Klein, who I met and worked with through the American Academy of Pediatrics. Michael has continued to embrace a true passion for children, connecting pediatric surgeons with pediatricians, pediatric subspecialists, and our trainees. Thank you, Michael, for inspiring all of us to remember the importance of compassion for and connectivity with our patients and their families. In his speeches, Michael always included the phrase, "The answer to any question is our children." Well, I was initially exposed to pediatric surgery in 1969 when, as a fourth-year medical student at the University of Pennsylvania, I elected a pediatric surgery rotation with Dr. C. Everett Koop. My first surgery case observation was a baby with severe pyloric stenosis, and I could not believe such huge hands could perform this operation on such a small baby. But Dr. Koop, like Dr. Klein, taught me to respect patients and families. So I titled my talk for today, All Adults once were children, as that phrase was my platform during the 3 years I served the AAP in a leadership position. The phrase states the obvious, but today I hope to convince you that there is a deeper, important message that we must acknowledge. Without speaking the word itself, Dr. Koop introduced me to the soul of a pediatrician, the soul of a physician, although I didn't realize this consciously for over 40 years. In recent years, I struggled to understand the new science. All of a sudden I gave away part of my talk, so I'm going to learn how to fiddle with these things appropriately. But I want to talk to you now about that soul of a physician. Not realizing that, I struggled to understand the new science that was advancing diagnosis and treatment and the business and politics invading the practice of medicine. I began to think more philosophically about who we are. I began to speak about the soul of a pediatrician, including specialists who care for children, as do you all. It is our ongoing concern for others, for children and their families, that serves us well as an introduction to soul. Our concern is reflected and our soul is defined as the ultimate internal principle by which we think, feel, and will, and as the core, the heart, and the spirit of who we are. So why is this important? If we are to succeed in our advocacy for children's health and well-being, we must recognize the sometimes tumultuous and ever-present change affecting our work and our lives. As we adjust to new regulations, electronic health records, variable payment systems, and the emphasis on productivity that sometimes precludes optimal personal connections with patients, it is sometimes difficult to balance the new with the heart and spirit that guided our path toward our work with children. A name you will recognize is Theodore Billroth, whose words come from his lectures on surgical pathology and therapeutics. He said, "Let what you observe penetrate your inmost soul. Let it so warm and replenish you that your thoughts constantly refer to it, and that you will find true pleasure and delight in your intellectual labors." Well, of course, the children we care for, if all goes well in their lives, will become adults. There is no possibility for an adult to evolve without experiencing childhood. One way to look at the transition from childhood to adulthood is explained with a quote from Theodore Geisel. And who would be better to teach us about children than Dr. Seuss? In 1958, Dr. Seuss wrote, "A child is the last container of a sense of humor, which disappears as he gets older, and he laughs only according to the way the boss, society, politics, or the race want him to. Then he becomes an adult, and an adult is an obsolete child." This quote takes us back to my title. Who we are as adults, the status of our health as adults, is significantly related to our ecology, our biology, and our social, physical, and cognitive development during early childhood. As we learn to recognize and teach the rapidly evolving science that underscores the need to think beyond advocacy to economics, policy, and system development by emphasizing children's health, the return on investment for investing appropriately in our young children will allow us to do what we must do: understand and manage change in the ways we think about health. We know that a young adult enters this phase of life with his or her brain, indeed the entire body, reflecting the health, education, and well-being of all his or her past ecology, social conditions, and life experiences through the previous years, thus determining the path of subsequent adult life. This concept, attention to early brain and body development, is important because it's the path to better lifetime health and well-being. It impacts all components of healthcare. It's the answer to our troubled economy, presently entangled in a health cost system that rewards fixing things that could have been so less expensively prevented. As pediatricians and pediatric surgeons, we know the important role that safe, stable, and nurturing relationships play in building healthy brains. The brain is exquisitely sensitive to early experiences. Now I'm going to find out which button to push. That one. A good example of what I've just mentioned is the 30 million word gap between receptive vocabularies among children living in poverty and other adversities compared to children living in stable, nurturing families. We know that brain development is a cumulative process with simple connections and circuits forming the foundation for more complex pathways and behaviors later in life. In January 2012, the American Academy of Pediatrics published a technical report and policy statement on early childhood adversity, toxic stress, and the need for leadership in the medical home and by all of us who interact with children and their families. To support all fellows in the American Academy of Pediatrics and all others, I hope all of you included, who have an interest in supporting children's healthy development, the AAP has created a new program, the Center on Healthy, Resilient Children. This is to build a stronger bond among pediatricians and all other physicians taking care of children to build stronger families and end toxic stress. I have the honor of being the initial medical director for the center. Our vision is simply a world in which all children have an opportunity for optimal brain development, the foundation for lifelong health and a stronger nation, while the mission will be using evidence-informed strategies, prevent and reduce the effects of toxic stress, a major threat to optimal brain development and the long-term health and well-being of our children and America's future. Key priorities for the new center include establishing practice-based policies, measures, and interventions, supporting community-based participatory research, supporting functional partnerships between healthcare and other systems, and uniting major stakeholders to jointly address toxic stress. We believe the true measure of a society is the health and vitality of its children. We know a child's development depends on the traits he or she is born with and his or her relationships with parents, other caregivers, and society. High-quality healthcare, a safe environment, and effective education are essential for children to thrive. But too many children in the United States are missing one or more of these essential elements and will not reach their full potential. A significant and illustrative example of health consequences is found in my own community, Tulsa, Oklahoma. A few years ago, a study was conducted in Tulsa County, comparing death rates according to zip codes. The variable was average income among the families living in each area. Study results demonstrated that people living in a very low-income zip code had an average life expectancy that was 14 years less than the average life expectancy for people living in the higher income level zip codes. At the time, access to health care, access to nutritious food, grocery stores, and increased violence in some neighborhoods were deemed to be the culprits. However, if we were to do the study again today, we would find that poverty itself, combined with poor schools, lack of social supports, generational impoverishment, and other factors influencing health and well-being among children in these neighborhoods, would be prominent predictors of shortened lives. Research in the 1990s focused on adverse childhood experiences, or the ACE studies. I ask this question to every audience. How many of you are familiar with the ACE studies? Thank you. That research began to inform us about the consequences of early childhood adversities related to later disease and dysfunction among adults. But it has not been until about the last 5 years or so that the validity and importance of the work has been widely recognized. Using a simple 10-item questionnaire, Doctors Vince Felitti and Rob Anda asked almost 18,000 mostly middle-class adults about the presence of adversities during their childhoods. The items in the questionnaire included physical, sexual, or emotional abuse, domestic violence in the home, drug or alcohol abuse by parents, parental criminal behavior, and mental illness in the home. For each adverse experience recalled, a score of 1 was assigned. Now, for those of you who are poker players, this study is one time when 4 aces is not a winning hand. In the initial study, more than half of the participants had an ACE score of at least 1, 13% had a score of 2, 7% had a score of 3, and another 7% had a score of 4 or more. Doctors Felitti and Anda found that there was a consistent linear increase in the presence during adulthood of many conditions related to the ACE score, especially when that score indicated 4 or more adversities that had been experienced. Some of the conditions are intuitive, like smoking and alcoholism, but some are not. For example, depression, pulmonary diseases, and heart disease. The study led to a startling conclusion. The adverse childhood experiences were key to determining the likelihood of the 10 most common causes of death in the United States. The risk factors for death at that time included smoking, severe obesity, physical incapacity, depression, suicide attempts, alcoholism, illicit drug use, injected drug use, and having 50 or more sexual partners, and with a history of sexually transmitted diseases. Yes, you heard right, 50 or more sexual partners, a dream of mine when I was 16. My wife told me not to say that, but what the heck. The study suggested that adverse childhood experiences were the most basic causes of health risk behaviors, of morbidity, mortality, and healthcare costs. Following this groundbreaking revelation, other researchers have confirmed connections between the adversities, also called now toxic stress, and poor health outcomes. When we add poverty and lack of attachment to parents, as well as perhaps later to community, the effects of adversities become one of the leading causes of problematic adult health. Unfortunately, this graph of public spending on the x-axis of a graph related to brain growth public spending on the y-axis with this graph related to brain growth reveals extraordinarily low funding in the bottom line, where the brain is developing at its most rapid rate, the top line. Between birth and age 5, you can see a great increase in brain growth and an almost static absence of any public spending on this age group. Funding then increases exponentially after the fact, emphasizing how the United States spends most of its money fixing or dealing with consequences like diseases and health and death, rather than spending on prevention. Just thinking about this spending fiasco causes me great stress. So I will focus for a few moments on stress. As you know, stress is a recurrent theme in our lives, but if we are resilient, we can usually manage the stressors and return to allostasis, a term that defines a successful state of balance between stress and calm. There is a second form of stress that is more intense, but still manageable or tolerable. However, when stress develops in a child due to chronic, unrelenting adversities, especially when the adversity involves or is caused by parents and other adults who should be protective, it becomes toxic stress. So rather than the up and down returning to normal you see in this slide, toxic stress is a prolonged response to continuing stress. In this circumstance, we refer to an allostatic load, which is defined as a level of ecological adversity that is beyond being tolerable. It is a level of stress that actually changes brain chemistry and brain function, creating propensities for diseases later in life. Toxic stress can even alter genetic expression through epigenetic changes in the genome. It is becoming increasingly important to realize that there is likely no greater group of threats to the health of children and adults as unyielding adversity. The influence of toxic stress, combined often with but not limited to poverty and ACE factors, is, in my opinion, the most important unaddressed public health issue in our country today. Well, I didn't realize it at the time, but I first learned about social determinants of health and the effects of toxic stress when I was a resident at the Children's Hospital of Philadelphia. During my first 2 years, I frequently encountered a boy in our emergency department who presented over and over again with severe asthma. Now, we didn't have treatments in 1969 through 1972 as we do now, but somehow we managed to calm the asthma storm and send Stephen home. Finally, during my third year of training, when Stephen was 14 years old, he presented with extreme distress, and at 3 in the morning required admission to my service. After a difficult struggle, his symptoms finally abated. Both Stephen and I were extraordinarily tired. It was then, exasperated and confused, I made a very unprofessional but valuable mistake. I looked at Stephen and I asked, "Stephen, tell me what the hell is going on?" With tears in his young adolescent eyes, he told me. He told me about his father's routine violence against his mother. He told me how he had witnessed this as a toddler, the time he first experienced severe wheezing and dyspnea, which explained the thickness of his paper chart dating back about a dozen years. According to Stephen, his father abandoned the family when he was about 3 years old, and interestingly, for a while, his asthma was manageable at home. When he was about 5, his status asthmaticus returned. At the time, his mother brought a new boyfriend into the home. Over the next 9 years, Stephen and his doctors at the hospital battled his asthma, never suspecting and never asking about his life at home, although they always asked about pets, dust, and mold. Stephen told me that the new boyfriend, now living in his home for almost a decade, continued to verbally and physically abuse his mother. As he grew older, Stephen tried to intervene, but he was small and weak and always started to have labored breathing and wheezing. Well, ultimately, we were able to obtain appropriate help for Stephen and his mother. The boyfriend was convicted on a charge of domestic violence, and Stephen's mother responded slowly, but responded to counseling. Stephen's asthma gradually and steadily improved. Now, this story, which is true, reveals my first realization that the ecology surrounding a child plays a large role in determining his health, in this case, both pulmonary and brain health. Knowing this, you will understand how many years later, as an attending in our pediatric teaching clinic, I confused residents as they presented cases to me. For example, a resident evaluated a 7-year-old second-grade boy for hyperactivity, poor attention, impulsivity, and poor knowledge retention. She proudly approached me. The attending related the signs and symptoms that she had found and confidently told me her diagnosis was attention deficit hyperactivity disorder, or ADHD, and her plan was to begin medication and reevaluate in a couple of weeks. But instead of agreeing with her plan, I thought of Stephen, and I asked this question: what can you tell me about the ecology surrounding this child? Ecology? Isn't that the study of what grasses and trees first grow around a newly forming river? In this case, though, we ended up discussing the child's home, his parents, his neighborhood, his community, his family's economic and work situations, and other ecological factors. Now, drugs for ADHD work if the diagnosis is correct, but do nothing to a child living in poverty or violence, or with a mother who is only 15 years older than her child, or with a school system that is underfunded, overcrowded, and with teachers who are themselves underpaid and severely stressed. These factors are the social determinants of health, the basis for allostatic load. They are significant contributors to not only the health of a child, but also developing health issues as the child becomes an adult. One area of health we are struggling with in both children and adults is mental health, but I really don't like that term. The other day, I had two meetings, one with the Oklahoma Commissioner of the Department of Health, and the other with the state's Commissioner of the Department of Mental Health and Substance Abuse. Why two meetings? Why two commissioners? Why is mental health a separate entity? Isn't the brain an organ in the body, just like the heart or the liver? We don't carry our brains around in a bucket. I know of only one example of a brain separated from a body: the headless horseman in Sleepy Hollow. Well, the term mental health evolved from the earlier term mental hygiene, a subject attributed to William Sweetser around 1843. It was actually taught in schools. In 1893, Isaac Ray, a founder of the American Psychiatric Association, provided a definition of the term mental hygiene. It is, he said, the art of preserving the mind against all incidences and influences calculated to deteriorate its qualities, impair its energies, or derange its movements. The management of the bodily powers in regard to exercise, rest, food, clothing, and climate, the laws of breeding, the government of the passions, the sympathy with current emotions and opinion, the discipline of the intellect, all these come within the province of mental hygiene. From hygiene to mental health to a separate entity. So I have been working diligently to move people toward the new term brain health. Brain health avoids stigma, it creates availability of care, equalizes payments for important medical interventions, and acknowledges what we now know about the relationship of brain function to stress, with the release and activation and reaction to cortisol, with aberrations in the neuroendocrine system, and with epigenetic changes. We can now measure the changes in size and function of areas of the brain like the amygdala and hippocampus following relentless stress. We can relate allostatic load to changes in the hypothalamic pituitary adrenal axis. We can now explain what the ACE studies revealed. Toxic stress alters brain functions and interactions with other organs in the body. Here is the reason. An adult person with an ACE score of 4 or more may have a significantly increased chance to have heart disease, chronic obstructive pulmonary disease, or one of several brain health issues. But not all individuals with a high ACE score have more than average numbers of health issues. There is an important mitigating factor we call resiliency. As we all recognize that adults once were children, we have begun to understand the health consequences of the balance between toxic stress and resiliency. We learn about this every time when we take a complete medical history. We include in that history an exploration of ecology. So, now we turn our attention to understanding resiliency. Once, after presenting the ACE study findings to a group of physicians, nurses, and others, I was approached afterward by a woman who wanted to ask a personal question about her life. She told me that she had an ACE score of 9, indicating an early childhood that must have been filled with terror, confusion, and a multitude of adversities. But she wanted to know about resiliency. She had an unusually high level of intelligence as a child, manifest by noticeable school performance and terrific grades in spite of her home ecology. Her elementary school performance led to a scholarship to a prestigious middle and high school, and where she continued to excel. This led to a full scholarship to college, where she obtained a BS with honors in nursing. She later married a physician, and both professionals are doing well personally and professionally. Her marriage and family were stable. She asked if I thought her intelligence and her passion for learning were the resiliency factors that staved off the consequences of her high ACE score. I believe she knew, as well as I did, that the answer to her question is, of course. But I realized that I didn't understand resiliency, especially as it might apply to a developing child. Simply stated, resiliency is the capacity to withstand stress and adversity and to properly adapt to stress. So, now we need to talk about the definition of capacity and how do we define properly adapt. I found a list of capacities on the internet that fits my thinking. The list is from the Australian Mental Health Foundation. I wish it had been titled the Australian Brain Health Foundation. But they list the following: rebounding, creative and flexible thinking, social competence, problem-solving skills, autonomy, and optimism. With this in mind, I turned, as I often do, to materials from the AAP, and in this case, one of its sponsored programs, healthychildren.org. Listed there is a book by Kenneth Ginsburg entitled A Parent's Guide to Building Resilience in Children and Teens, Giving Your Child Roots and Wings. Dr. Ginsburg describes the 7 C's of resilience. They are competence, confidence, connection, character, contribution, coping, and control. I think these items add to the understanding of capacities. For example, the first C, competence, can be thought of as the capacity to handle a situation. Children can be taught to focus on individual strengths, like the academic strength that promoted resiliency in the story I related about the successful nurse. Also, helping children learn how to make decisions falls into this category. Obviously, these concepts will apply to children as they are older and may have already become embroiled in an ecology of adversity. But with help, families could learn how to engage toddlers and older children to overcome the adversities of earlier years. Confidence is the capacity to believe in one's abilities. Parents, teachers, and other caregivers can focus on honest praise and pointing out skills inherent in an individual child. And I would add that every child has inherent skills. Connection can be thought of in terms of family ties, recognizing this can be a significant issue for a child who is maltreated at home. Ties to a community are also important and may be found through the faith community, schools, and community programs supporting children. Character can be defined as the capacity of having morals and values. Parents can help a child understand how his or her behaviors affect others. As you are beginning to see here, development of resilience depends on the parent's ability to parent. But if the parents are instead the creators of adversities and toxic stress, they are a large part of the problem. Here's a real dilemma, particularly when we advocate for schools and other programs funded by public dollars to put in place funded programs for children to both offset the negative ecology at home and to help build resiliency even in the parents themselves. The debate over intervention to promote childhood resiliency versus the so-called nanny state or interfering with families' autonomy will continue for a long while. And I can only hope that rather than seeing families as isolated dots on a map, we can eventually find the value in connecting those dots to create a resilient community and a resilient nation. Children need the capacity to serve others and to work as a team. This defines the C of contribution. Working as a team in schools or with siblings in a family to achieve a common group goal is one way to develop a sense of contribution. Coping is a way to deal with stress and to avoid shame and is best taught by example at home. But again, if the home is like Stephen's, the boy with asthma, other parts of the community will be needed to replace problematic parenting. Developing resources for parents like Stephen's mother will be important to promote parents' ability to model positive coping skills. Control might be defined as the capacity to focus on decisions. These are all very difficult to do when a child is very young, especially when living in an environment of toxic stress. Another part of resiliency is the ability or capacity to withstand some amount of unaccustomed stress, function during a crisis, and use brain reserves. It is unlikely that a child whose ecology is filled with an overwhelming allostatic load can achieve any of this without assistance, emphasizing the importance of someone, perhaps the teachers in the nurse's case I previously discussed, having the capacity themselves to recognize and support the development of capacities in young children. Well, I'd like to share a true story about myself to lighten the mood and demonstrate a capacity or two. This story is entitled, there they are, but you have memorized them all. This story is about Bobby Block's baseball heroics. Well, as a single child, I often had to invent ways to play by myself. I was fascinated by baseball, but lived in a neighborhood with only a few other children. And some of you may recall the game that I played often, holding a baseball bat in one hand, a ball in the other hand, throwing the ball in the air, taking a swing, hitting the ball to the other end of the yard, and then walking after it if you were successful, so you could run to it, repeat the procedure, and hit the ball back to your starting point. Well, I was about 9 years old, and I liked to invent stories as I played this game. And one day, it went like this. It's the bottom of the ninth with 2 outs and 2 on. Up to bat is Bobby Block, the world's greatest hitter. A solid hit will drive in the winning run. So I threw the ball up, quickly put both hands on the bat, took a mighty swing, and missed. Strike one. I threw the ball up a second time, took another mighty swing, and watched the ball drop to the ground as I missed again. Strike two. The crowd is cheering wildly for Bobby to get the hit we need to win this game. I threw the ball up for the third time. Strike three. So I picked up the ball from the ground. With the ball and bat in hand, I slowly retreated to my house. But I was resilient. As I walked, I said, "Ladies and gentlemen, you have just experienced the brilliance of the world's greatest pitcher." Focusing on positives rather than dwelling on negatives has potential to help families and their children become resilient. The Centers for Disease Control has developed and is beginning to implement a program entitled Essentials for Childhood: Steps to Creating Safe, Stable, Nurturing Relationships. My own subspecialty field, child abuse pediatrics, while continuing to identify and manage cases of child maltreatment, is moving more toward promoting factors supporting optimal child development, a pathway focusing on prevention and creating healthy outcomes arising from positive childhood experiences. In a 2014 Pediatrics Perspectives article published in the AAP journal, Pediatrics, authors Robert Segi and Jeff Linkenbach review the goals of the Essentials Project. They comment on physicians' ability to raise awareness of safe, stable, nurturing relationships, both with individual families and through community action. Quoting from their brief article, "The take-home lesson for physicians is simple yet profound. Health outcomes from positive experiences may be just as important as toxic outcomes from adverse experiences." Here's where you all will become part of the team supporting early childhood successes. Although you will not encounter the majority of young children as surgeons, you will see many surgical cases, and each surgical case is, in fact, a child connected in some fashion to a family and a community. Partnering with the child's primary care medical home, you can not only repair and treat the surgical condition, but your observations and input to the medical home can provide valuable insight into the structure and function of the child's family. But there's an even more important role for you as individuals and as a professional organization. That role evolves from the fact that all of us are members, often influential members, of our communities. Another quote from the article: "Physicians can influence the development of community norms commonly defined as values, beliefs, attitudes, and behaviors shared by most people in a group. That is our challenge. We should find ways to become involved in our communities, contributing time and treasure to programs that support parents' abilities to deal with their own histories of adversities and their abilities to create a positive ecology for their children." There's another way we can all help influence programs that support children. It's simply to take some time to engage in helping policymakers focus on the future by focusing on our children. We know now from sound evidence combining health outcomes with economic policies has predictive value. Professor James Heckman in Chicago, who is an economist and a Nobel Prize winner, says and speaks repeatedly about the return on investment being highest when the investment is made early in children's lives. Well, you may recall my earlier statements about our country's penchant for paying to fix rather than paying earlier to prevent. As president of the AAP, I had an opportunity to talk with a staff person from the United States Senate, who was responsible for working with the Congressional Budget Office, or CBO, on Senate bills. I asked her why our Congress could not see the value of investing early in programs affecting health, especially children's health. Her answer was surprising. She said they could never do that because the CBO only scores the cost of programs for a few years. And investments in children to prevent adverse health outcomes in adults would take at least one and maybe several generations and could not be scored. So to recap, we have work to do. We must manage change, recognizing the power of the soul of pediatricians and you, our surgeon colleagues. We must continue our advocacy for children's health and well-being and teach the importance of the all adults once were children introduction to lifespan health. Above all, we must continue to remind all who will listen and all who should be listening about the need for this nation to reject our current status reflected in child poverty, in health disparities, and in lackluster education often present in our K through 12 public systems. We must remind them also about the need for increased attention to the eco-bio-developmental model of childhood as a foundation for a healthier and more productive country. To borrow from President Kennedy, who said in 1963, "The needs of children should not be made to wait," we can say with some assurance that although children may be the victims of fate, they will not be the victims of our neglect. Yet our last 50 years' record of concerns for children does not reflect Kennedy's intent. Have children really escaped becoming victims of our neglect? In the United States, about 22% of children are living in poverty, and an alarming number are actually homeless. Economists have determined a living income for a family of 4 is somewhere around $45,000 a year. Almost half of America's children live in families below that modest income level, almost half. Our children are important representatives of the future of our nation and of the world. As we must recognize their value to us now and far into the continuing development of the human race, so must we protect and nurture them today and every day. We must recognize the ecologies, the changing environments in which today's children live. Our work will reflect our care, our caring, and our fervent desire that one day there will be no such thing as an adult who is only an obsolete child. But adults will be healthier and will enjoy a greater sense of well-being because our collective soul convinced our nation's leaders to invest in the resource most likely to create the greatest return on investment: our children. As Dr. Michael Klein reminds us, the answer to any question is our children. To return to where we began, I ask you all to think about the simple title of this talk: All Adults Once Were Children. When we are able to understand the power of prevention, the power of early, sincere intervention, we will improve the ecology of our nation as new generations of children evolve into our leaders and into the pediatric surgeons of tomorrow. I am most grateful for this opportunity, and I thank you all for the work you do every day to improve the lives of our children. Thank you for inviting me.